wedge pressure. So this is a classification of pulmonary hypertension into different groups by the WHO. Uh, and it's almost based on the causes for the pulmonary hypertension. The group one, as we can see, is a pulmonary arterial hypertension, and the causes could be idiopathic, genetic, drug or toxin induced, and are associated with non-risk factors from pulmonary arterial hypertension, such as the HIV, liver disease. The group 2 is called the pulmonary venous hypertension, which is often caused by the left heart disease, such as systolic or diastolic dysfunction, mitral or aortic valve disease. The group 3 is a chronic hypoxemic lung disease, which is often caused by the obstructive lung disorders, this obstructive sleep apnea, interstitial lung disease. And the fourth group is the embolic disease, and the group 5 is the miscellaneous, such as the causes like lymphatic obstruction, hematologic disorders, systemic disorders, and metabolic disorders. So it's a gross kind of classification of pulmonary hypertension into different groups based more on the causes leading to the pulmonary hypertension. Now, what is the pathophysiology? As we all know this, but I just want to review to again to this pathophysiology. The pulmonary hypertension first will cause injury, which can lead to an imbalance between endogenous vasodilators and vasoconstrictors. And that can lead to a vasoconstriction and formation of an in situ thrombi. So all these additional pathological processes can lead to a vascular remodeling, which will eventually increase pulmonary vascular resistance, and that will impede or impair the pulmonary blood flow. And that can eventually, or that can over time, it can lead to RV dilatation. So whenever there's an RV dilatation, we know the RV will be needing more O2, and that can lead to a ischemia and decrease in contractility of the RV. So when there's a decrease in contractility, the intraventricular septum can be shifted to the left ventricle more of volume overload. And if the septum is shifted to the left ventricle, it can eventually lead to the inadequate filling of the LV ventricle, and that can lead to a compromise in the cardiac output from the LV. So that is the pathophysiology of the pulmonary hypertension. Mainly, it can lead to a right heart failure, and that can further impede the filling and pumping of the LV. Now, what are the clinical features of how the patient presents to the ED? The most common presentation will be a dyspnea at rest or on exertion, and the associated history could be a syncope, a neosyncope, a fatigue, a lightheadedness. All these could be associated features. But as pulmonary artery pressure increases, it can lead to a typical heart failure features such as say, orthopnea, the paroxysmal nocturnal disease, the peripheral disease. So if the patient present at the beginning or at the start of the disease or the initial period of the disease progression, he will not be having a much symptoms or even the signs. But now the patient, when the arterial pressure increases, it can lead to orthopnea, PND, or peripheral edema. And similar to the symptoms, the examination findings will be normal in the early stage of disease, but with an increase in pulmonary artery pressure, as I have said earlier, it can lead to RV failure, and we can identify the typical features of the RV failure, such as the holosystolic tricuspid regurgitation murmur, jugular venous dilation, hepatomegaly, ascites, lower extremity edema. We all know these are the typical features of the RV failure. So if the patient present at as a severe progression during the severe progression of the disease, we can identify all these examination findings. Even on auscultation, we can hear an increased intensity of pulmonary component of S2, a parasternal heave may be observed, and subsymptomatic thrust in patients with right ventricular hypertrophy. So these are the examination findings which we can identify in a patient with a pulmonary hypertension. Now, coming to the diagnostic testing, what are the different diagnostic testing we can order and what are the features? In ECG, we can most commonly observe is the right axis deviation. Now, all these findings which I'm going to discuss in the ECG can only give an idea, or we can only give a thought on pulmonary hypertension, and these are neither specific nor sensitive to the diagnosis of the pulmonary hypertension. The findings are the RS ratio will be more than 1 in V1, RS ratio will be less than 1 in V5, V6. There will be a QR complex in V1, right atrial enlargement in inferior leads, incomplete or a complete heart block. And these, as I've said, are neither specific nor sensitive. So when we observe these findings, that should give a thought on pulmonary hypertension, leading and ordering the further diagnostic testing. The common dysarrhythmias or arrhythmias seen in the pulmonary hypertension are the AF, atrial flutter, AV model re-entrant tachycardia, and the atrial fibrillation, if found, is it could be leading to a mortality, because the arrhythmia which is associated with higher mortality is atrial fibrillation. So you can see an ECG, and I've said earlier the different findings we can see in this ECG, such as the QR complex in V1, the RS ratio will be more than 1 in V1, and the RS ratio will be less than 1 in V5, V6. But I've said the most common finding in ECG will be right deviation, right heart deviation. So that's what we can see in the ECG. Now, lab testing, the routine blood investigation may not be specific, but B-type natriuretic peptide may often be elevated. And coming to the imaging, the chest X-ray may show enlargement of the RA, RV, and pulmonary arteries. But the diagnostic tool is the transthoracic echocardiography. It is the best initial diagnostic tool in ED. It can identify the pulmonary artery systemic pressure, the decreased RV function, the RA, RV hypertrophy, and even the leftward deviation of the intraventricular septum may also be seen in the echo. So transthoracic echocardiography is kind of a diagnostic tool in ED. Now you can see the different views, uh, and you can see the first echo view, that the elevation of the arterial pressure, and we see the dilation of the inferior vena cava being full or plethoric, we say, and hepatic vein dilation. So all this is because there is a right atrial pressures are elevated, or the baseline pressures are elevated in the pulmonary hypertension. And the second is the apical four-chamber view of right and left ventricles. Here you can see a right ventricular hypertrophy with right ventricular trabeculae, which is indicating chronic right ventricular overload. And you can see the intraventricular septum slightly shifted to the left ventricle. And as we discussed, that can impede the filling and further compromise the cardiac output from the LV. So these are the echocardiographic views we can see in the pulmonary hypertension, which is the diagnostic tool in ED. Now coming to the treatment, so we have discussed the symptoms and signs. We have discussed the diagnostic tools. The treatment, there are 6 treatment steps. The first one is the oxygen and the mechanical ventilation. So always you have to titrate the supplemental O2 to maintain a level more than 90%. But the most important point in the oxygenation is, in patients with severe pulmonary hypertension, the intubation and ventilation can cause rapid cardiovascular collapse due to increased intrathoracic pressures from the positive pressure ventilation and effects of sedative medications on the right ventricular function and systemic vascular resistance. So whenever we need a ventilation, we always have to be careful and the following points must be noted. The TV, the tidal volume, must be maintained at 6 ml per kg, and a lower PEEP should be maintained to adequately maintain the saturation more than 90%. And the monitor serial plateau pressure and target pressures with less than 30 centimeter H2O, and the respiratory rate should be adjusted to avoid hypercapnia, because the hypercapnia can further lead to pulmonary vascular resistance and impede the blood flow. So mechanical ventilation, whenever we're thinking about mechanical ventilation in severe pulmonary hypertension, this point must be remembered, and it can have a higher chance of leading to a cardiovascular collapse. So these measures of keeping a low PEEP and TB, keeping low tidal volume, must be kept in mind when we're doing a mechanical ventilation pulmonary hypertension. Next point is the intravascular volume. The volume overload may lead to RV dilation, which, as we said earlier, can cause a shift of intraventricular septum to the leftward and compromise the LV output. And even in hypovolemia, serial bolus of isotonic crystalloid solution into 250 with close monitoring should be administered. Now, again, an important point to be noted in this intravascular volumes point is the usual methods of monitoring the volume responsiveness after administering an amount of fluid with ultrasonography is not reliable, as there is a baseline elevation in right-sided pressures. So we are doing ED. We have the monitoring, serial monitoring of the volume responsiveness with the sonar site. But whenever a patient comes with a history of or in severe pulmonary hypertension, this step is not totally reliable, as there's a baseline elevation, right atrial pressures, right side of pressures, and that can lead to a showing the IVC being full or plethoric. The third aim management tool is the RV function. So the pulmonary hypertension, as we said, can lead to a RV failure. So to increase the function of RV, the inotropes are commonly preferred, and the most preferred one is the dobutamine, and the dosage is 2 to 10 microgram per kilogram per minute. So doses more than 10 microgram per kilogram per minute can lead to hypotension. And the next option is the milrinone, which is a phosphodiesterase 3 inhibitor. Now, that it can reduce pulmonary vascular resistance. So it's the second preferred ionotrope and second preferred drug in the case of increasing the RV function. And the milrinone dosage is 0.375 to 0.75 microgram per kilogram per minute. So those are the two drugs which are used to increase the function of the RV. Now coming to the right coronary artery perfusion. So to maintain an RCA, right coronary artery flow, the arterial pressure at the aortic root must be higher than the pulmonary artery pressure. So the vasopressors, which is commonly used or preferred, is the norepinephrine, which are with a dose of 0.05 microgram per kilogram per minute. The higher doses may increase the vascular resistance, leading to an impairment of RV output. The dosage must be remembered, and it should be the norepinephrine should be preferred. Now, reducing the ventricular afterload is the fifth step, and this is done using pulmonary vasodilators, such as the prostanoids, the endothelin receptor, the phosphodiesterase 5 inhibitors. So these are the three drugs, the drug groups which we use to reduce the pulmonary resistance, or thereby reducing the ventricular afterload. Now, prostanoids are potential vasodilators, are used as the initial treatment for pulmonary hypertension and right heart failure. So the common examples are the epoprostenol, the treprostinil, the iloprost, and the epoprostenol is the only drug proven to improve survival. It has a half-life of 2 to 5 minutes and can be given in IV, intravenous peripheral IV line. The next one is the endothelin receptor antagonist. The common example bosentan or ambrisentan, and these can increase the exercise capacity and they improve hemodynamics, and these are given orally. But side effects are increasing liver transaminase and decreasing hemoglobin concentration. So these must be assessed further or later stage after the initiation of the endothelin receptor antagonist. The third one is the phosphodiesterase 5 inhibitor, which we commonly see in the area or see patients using like sildenafil or tadalafil. They can also increase the exercise capacity and improve hemodynamics in case of pulmonary hypertension. So that was 5 steps. So the 6th step is about disposition. So how to dispose a patient who present with a severe pulmonary hypertension. So it all depends on the condition of the patient, of how he presents. Now, as said in the previous slide, that the patient may present or may manifest different symptoms according to the stage of the course of the disease. So a patient presenting with ED with a severe pulmonary hypertension will be having features of the right heart dilation, the extremity edemas, and the murmur. So all these patients will be requiring admission, and a specialist, the cross consultation may be required. But a patient with presenting with a mild symptoms like mild dyspnea will be in the further or initial stages of the disease. So these patients may not be requiring admission, and they can, after complete evaluation, they can be sent home according to the source, according to the NALI. So this is how the patients are being disposed in the ED. So these are the 6 steps in management of the pulmonary hypertension. So that's about the topic on pulmonary hypertension. My source was Tindanali. Thank you.
Okay, Edwin, that was a very short, crisp presentation. Very nice. Okay. I think you've told the major points in pulmonary artery hypertension. Yes, it is not. Nowadays, it is something that we usually face, right? Especially on the other side in the era of COVID. So any small embolus and all that, which is, if there is a pulmonary thrombus, that itself, as time goes by, it is going to raise the pulmonary pressure. So the classification that you said, that the first classification is the WHO classification. Okay. Then
Yes.
yeah. So can you? So I hope everybody has understood the pathology of pulmonary artery hypertension. Like Edwin has correctly said it in a outflow diagram. So why do you have? So can a patient who presents to you with syncope have pulmonary hypertension? Edwin?
Yeah, yes, sir. He may have pulmonary hypertension because syncope can be due to heart failure, and one of the causes for heart failure could be pulmonary hypertension.
Okay, so pulmonary hypertension is going to cause an underfilled LV. So that is going to cause a decreased cardiac output and probably syncope because of that. Okay, so what are the common symptoms of pulmonary hypertension?
The common symptoms: dyspnea at rest or on exertion,
Okay,
and it can be presenting with even the orthopnea, paroxysmal nocturnal disease, edema.
okay. Right. So anything. So when you have a rise in the pulmonary artery pressure, what is going to get affected at the end of the day? Your right ventricle, your right side of the heart. Your RV is going to get affected. Your tricuspid valve is going to be affected. Your RA is going to be affected. Think backwards. So we have to assess for all these things in your ED. Okay. Especially if someone asks you, did you assess the RA, RV? In any case, now when I'm talking about pulmonary hypertension, this can be again attributed to pulmonary embolism or anything that is you're going to suspect an RA, RV dilatation. Okay.
Okay.
So before let's go step by step. You've talked about the classification. You've talked about symptoms. When you examine a patient, what all are you going to get in a case of pulmonary hypertension or raised pulmonary pressures due to any cause?
If the patient,
when you examine,
okay.
Yeah.
If the patient is having a underlying RV failure, on examination we can see a jugular venous dilation.
Okay, JVP might be elevated. Okay, so that is a probable sign of right heart failure. So what are the signs of right heart failure? Something that has been told again and again to us during MBBS days. The signs of right heart failure:
peripheral edema, ascites,
or more than ascites. Yeah, okay. So tender hepatomegaly and one more, raised JVP. So these are the three classical findings in a case of a right heart failure. So anyone who you see with a bilateral pithing pedal edema. Okay, so that is that. Next, something in particular to raised pulmonary pressures. You told me, you've already mentioned it actually. I'm just revising again, that's all. What is parasternal heave?
Right hypertrophy, right ventricular hypertrophy.
Okay,
That's a
okay.
pulsatile.
Okay. No, you keep your ulnar border over your sternum and you see whether there is a increased rise, right? But usually those things are, it might not, it's a very subtle findings. But more than that, what are the auscultatory findings that you're going to get?
The increased intensity of the pulmonary component of phase 2.
Okay, so you'll have a loud P2, right?
Yes.
You'll have a very loud P2. Okay. Then what all murmurs could come?
The tricuspid regurgitation.
So you can have a TR murmur. Yeah. So what is a TR murmur? Is it a systolic murmur or is it a diastolic murmur? TR. TR murmur is a systolic murmur. Systolic murmur. Okay. You can also have if you have pulmonary stenosis, what murmur are you going to get? Pulmonary stenosis. It is a systolic valve. Okay, ejection systolic valve. Correct, correct. So those are the examination findings. So once you've examined the patient, the next thing, the immediate what you have in your hand are what you have your echo and you have your ECG. So what are the ECG findings in a case of pulmonary artery hypertension? Again, the same question applies to what are the ECG findings in a case of pulmonary embolism, or what are the ECG findings in any case that is going to cause an RA-RV strain. So what are the ECG findings?
Right heart.
Anybody can answer.
Right axis deviation.
Right axis deviation. Okay, very good. Right axis deviation. Then you can have an RBBB, right? You can have an RBB. Then, like Edwin said, you have an R by S ratio. Okay, usually R by S and all that. That is R more than S. Okay, in R by S more than 1. So R will be more than S. Then one more finding.
P pulmonale.
P pulmonale. Very good. P pulmonale. What is P pulmonale? Anybody? Sorry?
Atrial enlargement.
Yeah, correct.
Right
you have the
atrial
right atrial enlargement. Right atrial enlargement. So how will the P wave be? How will you make a diagnosis of P pulmonale?
More than 2.5.
Yeah, more than 2.5 squares above. Okay, not towards the side. Just go vertically. Vertically more than 2.5 to 3 small squares. If you see a P wave like that, think of that is a P pulmonale. And whenever you see a P pulmonale, you have to think for anything happening in the right heart or the right atrium, and vice versa also. So if someone tells you there is something wrong with the right heart, you look at your ECG and you look for P pulmonale. If you see for P pulmonale on your ECG, look for something happening to your right heart. Okay, so we have ECG and echo, which are two things available in our ED. Now, what are the echographic findings? If someone tells you, okay, please assess this patient's RARV or the right heart, assess the right heart of your patient. You are in the ED. What all will you look for? I think maybe some. Okay, Sami, can you, Sami, could you answer that? If someone tells you to look at the right heart of the patient.
Sir. We can look for RARV dilatation.
You are looking for RARV dilatation. So what is RARV dilatation?
So the size of right ventricle,
okay.
It will be equal to or more than left ventricle.
Okay.
Or the septum might be bulged into the, not bulged, it will be straight. Instead of being bulged into the right ventricle, it can be straight, and we can see the D sign.
Okay, D sign. Okay.
And we can look for tricuspid regurgitation.
Okay, very good. You're looking for tricuspid regurgitation.
And
now, how do you say whether there is RA, RV? If I tell you, is there a RV systolic dysfunction, or is there an RV diastolic dysfunction? How will you assess that? Sami, you know this. We've discussed this earlier.
Sir?
We've discussed this earlier, Sami. I think you know.
Sir, this tabs, we have to check the tab C.
You have to check the tab C.
Annular plane systolic.
Yes, correct.
Excursion.
You have to check the tab C. So again, 1 minute. Edwin, could you just exit your screen?
Sure.
Yeah. Before saying that, before going into the echo, can Jumina tell me what are you going to find on the X-ray of a patient with right ventricular diseases or right heart diseases or pulmonary artery hypertension?
Sir,
Okay, yeah, tell me. You have a patient with with pulmonary artery hypertension in front of you. You are taking the chest X-ray of that patient. What all are you suspecting, or what all are you going to look for? Anybody? Anybody can answer. Okay, you can look for certain things like, for example, you can look for RV dilatation, right? You can look for a RV dilatation, so that RV can get hypertrophied. Okay, you can have a very rounded heart. I can't use the word globular because that is pertaining to something different. You will have a wide heart. That is your RV. When your RV gets dilated, your heart borders are going to be pushed outwards. Number one. Second thing is you will have your lung fields will look really black, will look oligemic, because there is your pulmonary artery is getting hypertensive, and therefore the relative blood flow that is coming towards the lung fields, all your bronchovascular markings and all that will be less in a case of pulmonary artery hypertension. And also, if you're that good to make out a pulmonary artery, then you're going to see the pulmonary artery to be really enlarged. So those are the X-ray findings in pulmonary artery hypertension. Or when I say pulmonary artery hypertension, that is even applicable to pulmonary embolism. Okay. So we've talked about clinical examinations. We've talked about ECG findings. We've talked about chest X-ray findings, and now we'll go into echo findings. So I've just Googled YouTube 2 videos to talk about the right heart assessment. Okay, so the first thing that you're going to see is, which is the first view that you're going to start with, and you do your echo.
Long axis.
Okay, you're going to do your long axis view. So when you do your long axis view, you're going to do, okay, this is long axis. Okay, this is not long axis. Okay. Okay, you're going to do your long axis view, then you're going to do your short axis view, then you're going to do your apical 4-chamber view. So you see this, can you see this image on your screen? You see the one on the left. This is how your normal LA, LV, RA, RV is going to look. So when you have a problem with the RA, RV, what is going to happen is that RA, RV is going to get dilated. So normally the RA, RV should be less than 2/3 of the LA and the LV. So if you see that this ratio is increasing, that is the LV is less than the RV, or the if the diameter is really more than 0.6 of the LV, then you can say that you have RV dilatation. So that is one common thing, or at least one you can eyeball your thing and say that, okay, my patient is called RA, RV looks full. But the next thing what I want to tell you is something called TAPC. So whenever someone tells you assess the right heart, you have to look for two things. You have to look for, one, the systolic function of the RV, and two, the diastolic function of the RV. So whenever you have something obstructing the RA, RV, or the pulmonary artery, you're going to have an increase in the systolic component of the RV. Similarly, when you have a right ventricular MI, what's going to happen? The RV systolic pressure will fall, or the RV systolic component will come down in a case of a right ventricular MI, for example. But here, what's going to happen? We are going to assess for the RV systolic function with the help of TAPC. Now, just a minute. Okay, so can you see this on the screen, TAPC? Is it clear? Yeah. So What is TAPSE? TAPSE is called tricuspid annular plane systolic excursion. It's in the name itself, systolic. So TAPSE means systolic. You want to assess the systolic function of the right ventricle, you look for TAPSE. So you see, this is your, just a minute. Okay, I can't point. You can, I hope you can see your RA, RV is dilated. Now see what's going to happen. Someone is going to put their M mode on the, someone's going to put your M mode on the lateral part of the tricuspid valve, that is the RV free wall. Okay, so this is what you will get when you put the M mode on the RV free wall or at the beginning of the tricuspid valve on the side. So you see this measure that they're taking. This measure is your TAPSE. That is all. Nothing more complicated than this. So the normal TAPSE is usually 1.7 centimeter and more. So that means if you have a TAPSE which is more than 1.7 centimeter, you can say that your patient is having a good RV function. So whenever you have this TAPSE to come down less than 1.7 centimeter, then you're going to say that, okay, my RV systolic function is bad. So there is something affecting that. Is it clear? Is it clear?
Yes, sir.
Yeah, I hope so. Nothing. So we've learned the RV systolic function. The systolic function of the RV you want to check. You go to your apical 4-chamber view. You press your M mode such that the line falls on the lateral free wall or the RV free wall at the junction of the tricuspid valve. You press your M mode and you see something like this comes, and you're going to measure from, I hope you understood from where to where. And if your value is 1.7 centimeter or more, you know your RV function is good. If you think it is less than 1.7 centimeter, that means your RV function, your RV systolic function is bad. Okay, so that is all about RV systolic function. Now, if you want to measure the RV diastolic function, you see this video. So what is this actually? It's already there. It's a tricuspid regurgitation. Like, is it clear for everyone that this is the apical 4-chamber view of the heart? And what you see, this whole thing is, just a minute. What you see, this thing is the RA, RV, and this is the tricuspid valve. And you see this jet, that blue color thing, right? That is the tricuspid regurgitation. Now, if you want to measure the diastolic function, what you have to do is, in the earlier thing, we took the M mode. Here you have to take the continuous wave Doppler. Nothing, it is just another button on your echo, on your sonocyte. You take the continuous wave Doppler, you put it alongside the tricuspid regurgitation jet. Okay, and when you get that, you're going to get something like this. And you see this value, you don't have to do anything. You just, the only thing you've done is you've pressed that button, continuous wave Doppler, and you're going to get something like this. And you see that value that is written V, velocity, 3.6. So that value, the only thing you have to remember is that value. If it is to go behind what pulmonary artery systolic pressure is, this is exactly how your echo finding is going to be in a pulmonary artery systolic pressure. You're going to have a 4 into all this whole square and right atrial systolic pressure and all. But we don't want to go anything into deep. The only thing that we want is to find out this part. What is the velocity? If it is around 2.8 and less, that means you have a lower pulmonary artery systolic pressure. If it is around 3.4 and more, that means you've got a raised pulmonary artery systolic pressure. So just remember the value 2.8 to 3.4. If you see that this value is less than 2.8, that means your pulmonary artery systolic pressure is low. It will be around less than 35. If you see that this value is more than 3.4, that means your pulmonary artery systolic pressure is going to be high. So that's the only two things that I would like to say. But regarding RA systolic pressure, RV diastolic pressure, because nowadays I found out when you shift COVID patients to your MD ICU, usually when they talk about the RA RV, they ask you whether there is RA RV dysfunction. So to comment on RA RV dysfunction, you have to talk about these two things. Okay. So right. So how do you when so again coming back to management of a case of pulmonary artery hypertension, what all are you going to manage? You're going to a patient, you have a COVID positive patient, you're going to intubate this patient. Suddenly, you see RA-RV dilatation, you see RA-RV dysfunction in this group, and you say if you know to see pulmonary artery systolic pressure, probably you're going to look for it again. And if the pulmonary artery systolic pressure is high, how are you going to go ahead with this case? Edwin has already beautifully mentioned regarding the management and all that. Could you just summarize it, Edwin? Just the management.
So, if you're going to with ventilation, the tidal volume should be at very less, like 6 ml per kg, and we have to keep a lower beep to maintain a saturation more than 90.
Okay. So first of all, we have to understand that intubation is always risky in a hypoxic patient. Number one, with COVID. Why I'm talking about COVID is because nowadays we see more of that. One, because of COVID. Number two, because of the pulmonary artery hypertension or the pulmonary embolus that is there. So always, number one, intubation is always going to be risky. You need a backup. So that thought should first go into your mind. Second thing is, whenever you intubate, you have to keep a low tidal volume, low peak. Now, okay, after that.
Then the respiratory rate should be maintained to avoid hypercapnia.
Okay, I didn't understand that. So when there is hypercapnia, what's going to happen?
Hypercapnia can lead to more of pulmonary vascular resistance and leading to a worsening of the condition.
More pulmonary vascular resistance. Okay, okay, yes. Okay. All right. It is the ulta of what's going to happen in the brain, right? When you have more of hypercapnia, you're going to have more of vasodilation in the brain. Okay, fine. Then
the plateau pressures must be noted.
Okay, that is okay. We know plateau pressure should always be less than 30. Okay, then.
Okay, that's a part in the ventilation part, and the next
part in the ventilation part. Now next
the RV
function. A, B, C. So we talked about A, B. Now go to the C.
The RV function.
RV function. Okay. RV function. So like Edwin said, the IVC is going to be really full in a case of pulmonary artery hypertension. So you might not be able to guide your fluid therapy, especially in a patient who's having a disease like this. So always use your fluids judiciously when you deal with a patient like this. Why? What's going to happen if you give lots of fluid, Edwin?
That can lead to a fluid overload, leading to again more of a shift to left side and compromising the left filling and cardiac output.
Very good, very good. So you give more of fluids, what's going to happen? The pulmonary artery is very tight, so there is no blood flow or very less blood flow through the pulmonary artery. So all the fluid that you're going to give is going to remain in the or what was already there is going to remain in the LA-LV, and if it increases, again, pulmonary edema and things like that. So if your patient's BP is 90/60 on a BiPAP, and you've decided to intubate this patient, and you know that this patient is having pulmonary embolism, is having hypoxia, is having pulmonary artery hypertension, what all are you going to do? What changes from your normal thing would you do? You're going to intubate this patient. You've already said that, Edwin.
Mechanical ventilation.
Okay, you're going to mechanically ventilate. Now you have to mechanically ventilate. The BP is 90/60 in your patient. Okay. Probably he's in cardiogenic shock. Definitely he's in cardiogenic shock.
Okay.
What are you going to do?
The first thing is to judiciously use the small amount of bolus dose for
Fluids.
access
Okay.
fluids.
Okay. Very. Or please do not jump and give fluids. Use very judiciously. Okay, maybe like around, I would say, if you don't have any clues, take around 200 ml or 250 ml first, max. That's all. Then
the next is the choice of ionotropes.
will you inotropes? So you're going to directly start. So you have a patient with 90-60 BP with the condition we've said, and you're going to directly start inotropes.
No, we have to wait for if there's a response after administration of bolus dose.
No. Okay, see, bolus dose is over. Okay, our fluids is over. Now I'm talking about vasopressors and inotropes. So you said you're going to start inotrope first. So which inotrope would you start first? That I'm talking about, you're going to intubate your patient. Okay, so that is the scenario. Are you going to start dobutamine? Are you going to start milrinone? Are you going to start something else first?
Norepinephrine.
Yeah. Why do you want to start norepinephrine first?
Because the RCA.
Okay, RCA. That one you've told that, right?
Yes.
Okay. You've told that is one point. Second point.
ബ്ലഡ് വെസൽ മാത്രം ആക്ട് ചെയ്യുന്നതാണ്.
എന്തോ?
വെസൽസിലും ബ്ലഡ് വെസൽ കോൺട്രാക്ഷൻ മാത്രം ഉണ്ടാക്കുന്നതുകൊണ്ടാണ്.
Okay, so whenever norepinephrine is given, what's going to happen? It is going to increase your preload. Okay, so always, first of all, you have to understand when you start dobutamine, there is always a risk for hypotension. So if you start dobutamine first on this patient's BP which is marginal, you're going to have a small problem. So you have to increase your systemic vascular resistance first. You have to see that perfusion is happening to your heart first, and then only start an inotrope. So always start a vasopressor first and go with an inotrope. You start noradrenaline and then you can start dobutamine if you want, but at least start noradrenaline there. That is the point to be noted. Okay, early use of vasopressors. Otherwise, whenever you start bagging your patient, again, if your patient is hypoxic, you're going to keep on bagging, and that itself is going to cause a very bad spiral, and your patient can go into severe hypotension and crash. So always be careful of the BP also when you manage a case of pulmonary artery hypertension or pulmonary embolus or increased pulmonary pressures. Okay, that is also a point that I wanted to make. I think overall, that's all what I wanted to discuss regarding this topic. Any doubts regarding what we've said?
So any significance for the vasodilators such as the?
Okay. So usually what the practice that is seen is you have to treat all sides. So giving a small dose of tadalafil, or earlier it was sildenafil. Sildenafil, now the drug uses tadalafil 5 to 10 mg. So giving that drug is definitely going to improve pulmonary artery hypertension if it is because of the reasons that we've said. If it's an embolus and all that, there's no point in giving. It's not going to do anything. But if you have a clear-cut case of pulmonary artery hypertension with all these complications, definitely there is no problem in giving tadalafil. Okay, you can give all these. You can decrease the preload. So this is step by step. So we've dealt with the A, we've dealt with the B, we've dealt with the C. Which drug causes more of tachycardia, dopamine or noradrenaline? Just a quick question. Which drug causes severe tachycardia, dopamine or noradrenaline?
Dopamine.
Dopamine. So dopamine, usually earlier in cardiogenic shock, they used to start dopamine as the first line of treatment. When the shock 3 trial and all that, shock 2 trial came out, they found out that dopamine should be replaced with something else, noradrenaline. So always start norad first, increase your systemic vascular resistance, see that you have a good blood flow to your heart, and then only start any other inotrope. Okay. Now, many people might have different views on this, but this is something that is usually commonly practiced because you at that juncture you don't want to risk anything. Okay, you have to maintain the map somehow. Okay. All right. So that's what I have to say regarding pulmonary artery hypertension. Any doubts? Is it clear? Is there something which is not clear?
Oh, clear.
Okay. Venu sir?
We'll close.
Okay, sir. Okay. Thank you, sir. Thank you.
Okay, sir. Thank you.
Yeah.